Thank you, madam. Good afternoon, everyone. The reason that I chose this topic is based on a few personal experiences which I thought that would be worth sharing. So to start off with, as rheumatologists, sometimes we all have come across those instances where we know there's some systemic inflammation going on for some reason, but the pieces of the puzzle don't all fit in to one place, and we really don't know where to go to. And this is an AI-generated image, and if you're thinking that AI could replace humans, you'll be able to pick that there is a error in it that does not make sense. I tried to ask ChatGPT to correct it, which it didn't. But somehow, now to start off with, I'll tell you a story of a patient who is probably the first complex patient that I managed after returning from overseas, who was referred by Upul sir, actually. So it was a lovely gentleman, 61-year-old, with a past history of TB, with a pleural effusion, and for some reason has had a pleurodesis also done, who gave a history of a mild respiratory tract infection about 2 weeks prior to the onset of the current illness, had been treated with azithromycin, sent home, but while being at home, he has started feeling ill again, where he was getting fever, he was getting a bit of a cough again, he had arthralgia, and he had these skin lesions, which were like a paniculitis, but predominantly it was on the back of the legs also. And by the time that I saw, there weren't really sort of acute lesions, but he had a few of them that were resolving. And his bloods were not very remarkable either. And so he had a ESR that was kind of around 30s, 40s. CRP again wasn't, striking. WBC, the full blood count, again didn't jump up. Nothing jumped up in it. Blood picture, as usual, it said either inflammation or infection. Everything else was done, and he had, in his previous X-ray, there was this small inflammatory shadow on the right, let me get the laser pointer, on the right around the lower zone. So he had an HRCT done, which said there's a consolidation. So because nothing pointed towards anything in this patient, there was a bone marrow biopsy done, screening for all infections, including COVID was done, and other autoantibodies were also done, including ANN and CAS, and nothing became positive. There was really nothing for us to go on. And while we were struggling to figure out what was going on, the patient, one fine day, we noticed that the patient's short of breath, saturation was dropping, so the patient had to be put on oxygen and sent to the ICU, and the repeat HRCT showed worsening lung lesions. And we were monitoring the ferritin, which was around 400, 300s initially. That was slowly creeping up as well. And at this point, I think, dragged Gunendrika madam also to the ICU to see this patient. And the respiratory physicians were still saying, no, this could be TB, because the patient has a history of TB. All other infection screening was negative. But because of the worsening lung lesions, we made a collective decision to pulse the patient with methylprednisolone, which we did. We gave for 3 days. Patient responded. Ferritins came down. We actually continued for another 5 days. And then once we stopped the methylprednisolone, ferritin started creeping up again. And when it reached about 6,000, 7,000, we decided that we can't sit on it. This could go wrong, and the only thing that we could think of that might be of use was tocilizumab. I actually spoke to my trainers overseas as well, and we decided we will give the patient tocilizumab, which we gave. And the inflammatory markers obviously came down with tocilizumab drastically. And at this point, with the worsening lung, but there was nothing else for us to go on. It was only the lungs that we could pinpoint to, and we thought that we needed a tissue diagnosis of some sort to base our management on. And this patient was referred to a cardiothoracic surgeon and underwent a lung biopsy, which was actually done through a VATS biopsy. And the patient's deterioration from that point onwards was something that we couldn't really stop no matter what we struggled. We really struggled to kind of get a hold of it. He developed, his lung collapsed, it was not expanding. Then he developed fistulae, which went into, he started getting subcutaneous emphysema. And you can see the serial x-rays, which are just worsening. And this was a few days into it. He had florid subcutaneous emphysema. And at this point, we had a preliminary report of the lung biopsy, which showed a florid inflammatory infiltrate, no vasculitis. But there was, EBV was put on the cards, and the pathologist felt that it could be an EBV-related rare form of large B-cell lymphoma that can occur in the lungs. So although there was a discussion to go for a second dose of tocilizumab, we couldn't do that with this EBV being on the cards. So we were awaiting staining. That was, one report was to come from India. And while awaiting all that, the patient succumbed in the ICU, and I was there when the patient actually died. And to me, this epitomizes horror ototoxicus that was first described by Paul Ehrlich, who's a German physician, an immunologist, who actually won the Nobel Prize in 1908, if I'm not mistaken, for his work on immunity. And serendipitously, another Russian immunologist shared the Nobel Prize that year for the discovery of phagocytosis, which is like the rudimentary part of our innate immune system. And Paul Ehrlich actually used this term horror ototoxicus to describe fear of self-toxicity. And at that point, he was actually describing autoimmunity. And about a century later, what we're talking about is horror autoinflammaticus. It's the inflammatory response that we're talking about. And this word autoinflammation actually came into use much, much later. It was first used in literature in 1997 to 1999. And to understand what it means, we need to go back to our immunology and look at the two main systems of our immune system. So we have the adaptive immune system, where the body launches a response to a specific antigen that it recognizes, and it has a memory. So that's our adaptive immune system. But then we have the innate immune system. That's the first line of defense for anything that comes from outside, starting from our physical barriers to the different cell types that are involved, including the granulocytes, the macrophages, basophils, eosinophils, mast cells, to the monocytes that differentiate into the neutrophils and the dendritic cells. And we have the natural killer cells, which are sort of mopping up the infected cells or the dying cells. And at the intersection of it, we have the cytotoxic C cells and the natural killer cells. And of course, the antigen-presenting cells, the macrophages and the dendritic cells, activate the adaptive immune system as well. So what we are talking about today is this autoinflammation, where the dysregulation and hyperactivity of the innate immune system is causing a systemic illness, as opposed to the adaptive immune system getting dysregulation, causing an autoimmunity. So in the initial publications, you can see that there's a clear demarcation between this autoinflammation and autoimmunity, where autoimmunity is due to the breakdown of self-tolerance, where the body's adaptive immune system starts recognizing self-antigens and producing autoantibodies. Whereas autoinflammation, there is no breakdown of self-tolerance, but the innate immune system gets activated and becomes hyperactive, to cause a disease. So the predominant cell types, as you can see, would be very different, whereas the B cells and the T cells will be involved in autoimmunity, and autoinflammation will be, it'll be the innate immune system cells, the monocytes, the macrophages, and the neutrophils, and the tissue damage occurs due to this neutrophil and macrophage mediated inflammation that occurs in autoinflammation. And in the initial publications by McDermott, they have clearly given a few autoinflammatory diseases, which is actually labeled as a partial list of autoinflammatory disorders, because they would have also understood that this is going to be an expanding list even in 2000 and 1999, etc. And we know today from our expanding understanding of the immune system that it is not, this demarcation is not so clear often, because we know that even if the primary pathology is due to an autoantibody, that could lead to the adaptive immune system getting activated and leading to chronic inflammation. And it could happen vice versa as well, where the primary pathology could be an autoinflammation, but as the antigen-presenting cells recognize those tissue antigens, the adaptive immune system can get activated. So there can be a secondary component of autoimmunity coming in as well. So with this, now the current concept is that all these systemic inflammatory diseases that we are seeing fall into a spectrum, where at one end we have autoinflammation, pure autoinflammation, which are mainly these monogenic autoinflammatory diseases. So the famous one that you would know is familial Mediterranean fever, and TRAPS and CAPS and Blau syndrome, and there are so many like that, about 60 to 70 have been described up to now. And then on the other spectrum of the end spectrum, that you have autoimmunity. There are very rare monogenic autoimmune diseases as well, but diseases like systemic lupus erythematosus is a prototypic autoimmune disease that we commonly see. And everything else falls in between, where we have polygenic autoinflammatory diseases with no autoantibodies that are present, but so ones like inflammatory bowel disease and even gout, pseudogout, sarcoidosis, classical example of adult onset Still's disease. So these are polygenic autoinflammatory diseases. And then we have those that where there's a mixed pattern. Again, no autoantibodies that are recognized, but they have features of autoimmunity and autoinflammation, like spondyloarthritis and Behçet's and inflammatory uveitis. And then we have predominantly autoimmune, but with a component of autoinflammation, like rheumatoid arthritis, celiac disease, etc. So what you'd be familiar with, most likely, are these monogenic autoinflammatory diseases, and they have a Mendelian inheritance where it's either like, for example, certain ones are autosomal recessive. Familial Mediterranean fever is predominantly autosomal recessive, whereas CAPS is predominantly autosomal dominant, but we get the sporadic forms as well. And then we have the polygenic ones, where it's multifactorial, where there are permutations and combinations of genetic factors, and there are epigenetic factors as well, like environmental factors, either things like smoking or infections that will trigger the pathogenesis or the pathogenic processes in these diseases. So I will not be talking about these monogenic systemic autoinflammatory diseases. There's just a few, there are so many, but majority of them, in the systemic ones, you will see fever, and depending on the syndrome, you will see other types of clinical manifestations. And essentially, the diagnosis depends on recognizing the clinical syndrome and genetic testing. But even in more developed countries where there are facilities to do genetic testing, one of the problems is that we can't test for all the genetic variants. We can generally test for only the common ones. So sometimes the diagnosis is still not confirmed, even in the cases of FMFs that I've seen during my overseas training, and even things like data vasculitis. But what I'll be talking about predominantly are these polygenic systemic autoinflammatory diseases. And so there is no single genetic mutation that is identified, but there is dysregulated activation of the myeloid compartment with autoinflammation. Classic examples, adult onset Still's disease and systemic JIA, Behçet's, IBD. And there are other rare ones that would be of sort of interest because of the grey cases and the exams that are coming up. So, but these are very rare for us to come across. But another thing that we have seen, or maybe we are noticing it more after COVID-19, are the post-infectious inflammatory reactions. So essentially Kawasaki and reactive arthritis are post-infectious autoinflammatory diseases. And with COVID-19, we've started talking about multisystem inflammatory syndromes in children and cytokine release syndromes. Now, cytokine release syndromes can happen, they're most commonly happening with things like CAR T-cell therapy and different immune modulatory therapies, but it can happen post-infection as well, including after COVID-19 and even EBV viruses and sometimes after influenza infections as well. And retrospectively, this is what we feel. Finally, after the patient actually passed away, we got the final immunohistochemistry staining and the histology, which just showed florid inflammation, no EBV, nothing else. It was just florid inflammation. So looking back now, what we feel is that it was likely some form of a respiratory infection that triggered off a massive inflammatory response that just went out of control after a certain point. And to me, this is horror autoinflammaticus for a couple of reasons. One is that there is seemingly unprovoked systemic inflammation. And in majority of these cases, you would see that after a certain point, there is sudden and rapid progression with deterioration. I will give you another example in a bit. And when we fail to intervene at the correct time, the outcome will be worse. And in this case, unfortunately, the patient passed away. And there were so many overlapping and non-specific symptoms where everything else was still on the cards. There was talk of infection, there was talk of malignancy, there was talk of still autoimmunity, something that we could be missing, and all these things were still quite possible. And the key in it is that we figure out or put our foot down and say, okay, that is it, we need to intervene, we need to do something so that we don't end up in a situation like this where we're too late to catch the boat. And the second patient is actually a patient that we saw some time ago, even during my training. And so it was a young female who came with high spiking fevers, again referred from a medical ward with arthralgia, but there was a history of sore throat. And this is actually her fever chart. And if you can see, there are high spiking fevers, and it was coming to the baseline as well in this case. She had high inflammatory markers, WBC count of 18,000. ANA was positive, it said a fine speckled pattern, and because of the ANA, probably they had already done a C3, C4 by the time that they referred, and they had done a whole heap of screening for infections, but still thinking of infection. The patient was on doxycycline when we saw the patient, and the patient was referred to us, I think predominantly because of this ANA was positive. But when I went to see the patient, this is the rash that the patient had. And the patient was febrile as well. And fortunately, it was a very fair-skinned patient. And by this time, from a rheumatological point of view, everything should ideally fit into place. And if you can see, the rash shows a very characteristic co-obnerization as well. And this is a classical rash that we get in adult onset Still's disease. And the only thing that was not there was a serum ferritin. When we asked for it, it came back as 15,000. But still, there was a talk of infection. And we were finding it difficult to convince them, no, this is Still's disease. We need to go ahead and intervene. And while we were waiting, the next day, only the full blood count was available by morning. And if you notice, the full blood count earlier had a bit of a thrombocytosis. Here, the platelet count was only 208. By afternoon, ESR was there. It was 30, coming down from 80. But the patient developed seizures and had to be put in the ICU. And that's when we started methylprednisolone pulses. And this patient actually survived but had an ICU stay of about 1.5 months with all kinds of complications. Again, not responding to steroids alone, where we had to resort to tocilizumab because that's the only thing that we thought that could work, that was available to us. But fortunately, she survived. But that also shows us that there can be very sudden and rapid progression and rapid deterioration with these systemic autoinflammatory diseases. And also the fact that there are no specific biomarkers for us to go by. There are no diagnostic tests as such. With autoimmunity, it's quite often straightforward if things fit into place. If we find an antibody positivity, we put the pieces together and it becomes quite easy. But these diseases are often diagnoses of exclusion, where we exclude everything else without a specific test for diagnosis, which makes it more difficult. And the presentations can also vary. So always all the other differentials that we spoke of are on the cards. And in addition to that, particularly things like adult onset Still's disease and other periodic fevers, they're episodic. And sometimes they can resolve, sometimes on their own, sometimes with NSAIDs. And because of that episodic nature, they have a tendency to get treated as infections for each of these episodes, and you can miss diagnosing them for a long period of time. Then on the other end of the spectrum of the two cases that I just described is this lady, a patient that I was involved in managing during my overseas training, actually, not here, who was of Indian origin, a young female, coming with low-grade fevers for about a month, with loss of weight, arthralgia. There was lymphadenopathy. There was hyaline-lymphadenopathy in the X-ray, and there was some cervical lymphadenopathy as well. And so with that, when you're working in the UK, one of the first things that you would think of is sarcoidosis. So calcium just marginally elevated, ACE just marginally elevated, and the lymph node biopsy showed non-caseating granuloma, so that's what was reported. The quantiferon was positive, but AFB was negative. So to us there, this was sarcoidosis. And so the patient was started on prednisolone, 40 milligrams daily. Initially, there was a response. The fevers reduced, the symptoms reduced, but then in about 2 weeks, again, the symptoms were worsening. The patient was feeling unwell, and it was decided to start the patient on infliximab. So the patient got 2 doses of infliximab and then got admitted with high spiking fevers and a cough and a florid diarrhea with generalized lymphadenopathy. ESR was up the roof, and after struggling for a few days with the patient, she had a repeat biopsy, and TB-PCR was positive in the repeat biopsy. So that is the other thing, the other danger of dealing with these autoinflammatory diseases. And forever as rheumatologists, we are at this tug of war of whether this is infection and whether this is not infection. And there's always this ongoing debate with sometimes the physicians, sometimes the respiratory physicians, and even in our heads, we often wonder, could this be infection? Could this be infection? But there comes a point when we have to decide when everything else is becoming negative, where we would have to take that risk and say, no, so far everything else has become negative. We can't wait anymore. But we shouldn't be so trigger happy to forget infection, like in the last case, particularly without considering the patient, particularly without considering our context, where infections are much more common, so that we miss infections as well. And the other reason why I feel that these are actual horrors to manage is because sometimes it would feel as if you're battling a huge fire-breathing dragon with just not a sword, but a little pocket knife. That's what sometimes it would feel. Because when you look at the therapeutic options that are available, we have, of course, the NSAIDs, we have the corticosteroids, we have the conventional immunosuppressants, would they work, and we have the targeted therapies. So we have tocilizumab, we have TNF inhibitors in Sri Lanka, we have JAK inhibitors. Again, the availability is questionable, sometimes not there, sometimes we can't get it. Even in the private sector, it's very expensive. And we don't have anakinra that's registered in Sri Lanka at the moment. So essentially, if we break it all down, the therapy is based on the disease pathophysiology and the immunological mechanisms behind it. And to figure out what would work, we need to understand how these diseases happen. So when we look at the the innate immune system, we have the pattern recognition receptors, which are either on the cell surface or inside cells, which recognize either these pathogen-associated patterns, or PAMs, or damage-associated molecular patterns, or DAMs. So, and these recognition of particularly DAMs makes these pattern recognition receptors form multimeric protein complexes within cells that we call inflammasomes. And formation of these inflammasomes generally lead to activation of what we call caspase-1, which then cleaves particularly interleukin-1 beta and interleukin-18 into their active forms and releases them from the cells. And in addition to that, we have NF-kappa, nuclear factor kappa B, which gets activated, again through either antigen-antibody interactions or by cytokine signaling or by pattern recognition receptors recognizing PAMs or DAMs, which also leads to increase in production of inflammatory cytokines and releasing them from cells. And that also leads to a process called pyroptosis, not apoptosis, pyroptosis, which is inflammatory cell death, which happens much, much more quickly and much more aggressively. So when we look at the therapeutic options that we have, the conventional DMARDs essentially work on T cells and B cells. That's where they work. So majority of these conventional DMARDs will not work for autoinflammatory diseases. But then we have ones like colchicine, which actually inhibits the microtubule function and interferes with the function of the inflammasomes. So because of that, that's why colchicine is one of the main things that are used in autoinflammatory diseases like FMF. And then we have the cytokine blockers like anakinra, canakinumab, and in certain diseases, particularly those that are related to NF-kappa B pathway dysregulation, TNF inhibitors are also used in treatment. So these ones would work. And in certain instances, tocilizumab would work. But interesting point is about Janus kinase inhibitors. So JAK inhibitors, actually, tofacitinib was FDA approved in 2020 for the use of JIA as well. So with JAK inhibitors, what they do is they block the interferon pathways. So they do work for autoinflammation as well. And they are being used. And as I told you, tofacitinib was just approved 5 years ago for polyarticular JIA. So there is a place for using JAK inhibitors in some of these instances. But whatever that we select, we need to go by the possible pathophysiological mechanism based on a clinical judgment of what type of syndrome that we're dealing with. For example, if you think of HLH and macrophage activation syndrome, this is the predominant pathology in that case is a macrophage activation, and it's a cytotoxic T cell driven process. So we get high interferon gamma signals, IL-6 not so much, and ferritin will be high and IL-10 will be high. So in these instances, it's anakinra that would work best. But when we think of cytokine release syndromes, it is due to an hyperactive monocyte macrophage, and it's also driven by T cells, but the predominant cytokine involved is interleukin 6. Interferon gamma and TNF alpha and interleukin 1 beta is there, but the predominant one is IL-6. So that's why for cytokine release syndromes, tocilizumab works very well, for example, with COVID-19. And between macrophage activation and cytokine release syndromes, there are sort of clinical differences as well, because in both, although we get cytopenias in cytokine release syndromes, the cytopenias won't be so high, ferritin won't be so high as macrophage activation, and with those we can make a good clinical judgment of what we're dealing with and decide on which way we should lean. So these diseases are horror autoinflammaticas because they pose a therapeutic challenge as well. We have limited availability of targeted therapies. Cost is always a barrier. And with the targeted therapies that we use, like in the third case, risk of infection is always there. So it boils down to us to figure out what it is and decide on what would best work for that patient based on the disease pathology. And of course, revising immunology itself could be a horror to some of us, but sometimes we need to go down to that level to figure out what would work. So these autoinflammatory diseases can be confusing. Sometimes we are lost, sometimes we are puzzled as to what to do. And as I showed you, they pose a huge diagnostic and a therapeutic challenge, more so in Sri Lanka, because of the limited availability of resources. And that first patient, I was actually looking at whether we can get the IL-6 levels done at one point to convince everyone, no, this was autoinflammation. We need to give the second dose of tocilizumab, but it was not available, and there was no way that we could get it done in time. And often we will never have a confirmatory diagnosis of these instances. So it's up to us to rely on pattern recognition, and where we often think of autoimmunity, but we forget the autoinflammation. So we need to keep that as a differential when we see these systemic inflammatory syndromes in patients, but not to be careless to miss infections, to be prudent enough to consider infections and to not to be too trigger happy, to forget them and to jump the gun, but to consider it as a differential. And when things are falling into place and everything else doesn't fit, to decide when we need to intervene and intervene at the appropriate time so that we are not too late, as in the case of the unfortunate patient that I just described. So thank you. CRP wasn't very high, so it was like 16, 20, kind of very. Right. It's liter higher. Yes, sir. Yeah, sorry, that was a mistake. Yes. Yes, sir. So the thing about macrophage activation is that it can happen due to anything. It can be due to like these hematological cases where you see a genetic predisposition and they get HLH primarily. And then we see the autoimmune diseases and autoinflammatory diseases like stills that go into HLH, in which case we call it macrophage activation. And even with cytokine release syndromes, secondarily we can get a macrophage activation and get macrophage activation. But in this patient, the count started dropping very, very late. It was never low to begin with, and it was, to me, I think anyway the bone marrow biopsy was done quite early, so that wouldn't have picked up anything. But the count started dropping very late, and at that time I think the patient was on cotrimoxazole also. So I'm as puzzled as you are about this patient still. Yes, madam. Yeah. Plasma exchange. Agree. Yes, madam. So etoposide, yes, it is sort of for primary HHS, and there are instances even with secondary we could use it. It's essentially sort of topoisomerase inhibitor, so it should work for the immune cells also. Cyclosporine definitely, and with plasma exchange, as you said, there's no definitive evidence, and plasma exchange would essentially remove the large molecules. Yeah. It goes back, yeah. Thank you, madam. Yes, so that is always the challenge. It can look so much like infection, and sometimes generally procalcitonin is not that high, but it can still be elevated to a certain extent, even in these cases. So it's predominantly, if we have tested for everything and all the cultures keep coming negative, then we need to seriously think, are we going to, and we are treating, of course, in these patients, we always treat with, cover with antibiotics. And if that's also not working, we need to clinically make a judgment that, okay, everything has come negative, not antibiotics don't seem to be working, and we don't have a possible infection. That's, but otherwise they look very, very similar. So. Thank you.
Doubts that have plagued us for a long time, yet another excellent delivery from you. So moving on, we know that amputation is a life-changing event. So the next talk is on From Limitation to Liberation, a holistic approach to amputee rehabilitation, delivered by Dr. Dinusha Samarakoon, Senior Registrar in Rehabilitation Medicine, Rheumatology and Rehabilitation Hospital, Ragama. Over to you, Dinusha.
Thank you, Madam. Good afternoon to you all. And first, I would like to thank my College of Rheumatology and Rehabilitation for giving me this opportunity to perform. Today's my topic is From Limitation to Liberation, a holistic approach to amputee rehabilitation, mainly focusing on lower limb amputations. Amputation, actually, it is the most ancient surgical procedure which has recorded in the history. So the history extends back beyond 18th century, where even the anesthesia even not introduced. So definitely it would have been a very crude procedure at that time. So with that, we can think that suddenly losing a body part of a person who was using for years and since birth, it's actually a really challenging and redundant event of this event. So it actually leads to a huge physical disability and also a huge psychological impact for that person. So turning to the static data, in 2017 in Sri Lanka, there had been around 160,000 amputees were recorded. Most of them were veterans at that time. And at that time, the global counts were as high, were around 57.7 millions. And there are also UK amputee rate also recorded as 11 per each 100,000 in the population group age 25 plus. So considering etiologies and non-traumatic etiologies, diabetes is the commonest cause for lower limb amputations that is appear to be worldwide. And further, commonest level of amputation appears to be below knee amputations. And lower limb amputations found to be common in males, around 74%, and it has found to be common in the age group 40 to 60 years. That's very important because it would be a very affecting burden to the country because the age group represent the working population in a country. So that's why amputee rehabilitation is such important in our health sector. So because of this amputee rehabilitation, amputation would not be the end of a story, but it would be a good beginning of a new pathway. So goal of amputee rehabilitation is to achieve the maximum level of activities of daily livings, which is the good and best predictor of quality of life of a person, and return them to the highest possible level of social reintegration with optimum psychological well-being. So next, I would like to take you through the amputee rehabilitation process, which can easily discuss by dividing the process into few important phases, such as beginning with pre-amputation phase, and then amputation or the surgical phase, post-amputation, and the pre-prosthetic amputee rehabilitation phase, then moving to the prosthetic rehabilitation, and the follow-up phase. Amputee rehabilitation is much time consuming and it's a long journey actually. So it definitely have to involve multiple expertise which represent different disciplines implementing their expert knowledge to achieve a common goal. So keeping the patient in center, they are working in their scopes but always overlap is acceptable. So that is a multidisciplinary team approach, and rather would say interdisciplinary team approach. So that is very important in amputee rehabilitation to gain and achieve the maximum outcome for a patient. Starting from the pre-amputation phase, so we can say this is actually the base of the amputee rehabilitation process. So it starts since the amputation become an option for patient's management. Good communication between the surgical team and the rehabilitation team is really paramount in this case. And when a person is planned for an amputation, and when he is referred to the rehabilitation team, the first contact with the rehabilitation physician, he will assess the patient and he will arrange, rehabilitation physician have to arrange the patient, multidisciplinary team discussion, mainly involving the patient, his family, and also all the members involved in the multidisciplinary team to decide on the fitness of the fitness of the patient to undergo this surgical procedure, and to decide on the level and the surgical procedure which is the best for the patient, and also considering all patient expectations and all the realistic and non-realistic goals. Further, we have to decide on future mobility plans, whether the patient is going to walk with the prosthesis or whether is going to use a wheelchair in the future. And also the arranging peer review groups in this phase is really important to share the experience between the patients with similar impact to share their experiences. And again, starting of physiotherapy in the early stage, since this pre-amputation phase again has a very important place for muscle strengthening and to minimize the deconditioning of the body. If the person was preoperatively well ambulant, the level of amputation will be the level with mostly beneficial for the ambulation of the person. And primary wound healing rate may be the determining factor if the patient is not planning for further mobility using prosthesis. So again, the preservation of knee joint and the level of amputation also important. Even the patient is going for a wheelchair also. So why is that? If the patient has a good length of the residual limb and the preserved knee joint, it would help for the even pressure distribution while the patient is in sitting position. And again, it would help for transferring of the patient. So considering all the things, we have to decide the best level of amputation with a good discussion and communication with the surgical team and rehabilitation team. So the common lower limb amputations that we perform are transtibial amputations and transfemoral amputations. Transtibial amputation is the commonest surgery we perform in lower limb amputation, and other possibilities also in the transtibial amputation. There is trans-ankle ankle disarticulation and also knee joint disarticulation, and transfemoral amputations level, there can be several levels. Yes, this is this picture illustrates how the through knee amputation surgery is performed. So actually this is a very easier procedure for the surgeon and also a quick surgery. But there are considering for the patient, there are several advantages because with a preserved knee joint, he would get a far better gait pattern, and it will lead to reduced energy expenditure during gait and also better endurance. But when the prosthetic rehabilitation comes, it will may be some challenging because when the patient is preparing for a prosthesis with a preserved knee joint, there may be some differences of the residual the surgical side and also in the sound side. So there may be possibilities to cause length differences within the two femurs. So we have to consider all these pros and cons when we decide on the surgical level. Yes, this shows energy expenditure correlated to the amputation level. You can see the more distal surgery will cost minimal energy cost, and when the surgery is more proximal, it needs a higher energy cost for the patient. So during the surgical phase or the amputation phase, the experienced orthopedic surgeon should have to ensure the best and optimum surgical process for the patient, and to hand over the best stump for the rehabilitation team to facilitate the further rehabilitation process for this person. So during the surgical procedure, it is very important and the responsibility of the orthopedic surgeon to ensure adequate blood supply to the remaining stump, and to consider the scar, and as it should be in a place where the pressure is not much exposed, and it should be freely mobile, and the skin should not be in a folded condition, and the bony end should not have sharp ends or spikes to improve and to get a far better healing process, and also preservation of the optimum limb length and knee joint especially. Also helpful during the surgical process. So surgeon has to ensure all these things and do the surgery according to the to give a good stump for the patient for helping his rehabilitation process in the future. The post-amputation phase, that means the acute post-surgical rehabilitation phase, mainly involving the wound management and the prevention of edema and also pain control. So again, starting physiotherapy since the early post of day one, also very important to avoid complications as residual limb and frontal limb pain, and also the to minimize the cardiovascular and pulmonary complications in the person. So from the post-op day one, physiotherapy team have to see the patient and start the relevant interventions involving breathing exercises, resistant exercises, and active and passive range of motion exercises. Also, skin desensitizing techniques, and positioning, and also initiate walk-in and train the patient to start independency for activities of daily living also should start from this position, considering the patient's fitness and tolerability. Further, massaging and tap into the skin and desensitization and scar mobilization also important, which help reduce the pain and by improving circulation of the remaining shaft, and also doing those things that procedures help to patient to get adjusted to the new body image also, and it further help to prevent pain and blister formation during prosthetic phase. And during this acute post-surgical phase, other than the wound dressing, we are applying a dressing to the residual limb. To achieve the, to protect the limb and to reduce the shaft swelling, and it also helpful to create the best conical shape for the remaining shaft, and also it helps for prevent contractures. So there are several types of dressings. Commonly what we use is soft dressings that are elastic materials or cream bandages and compression socks. Usually we use it in figure 8 pattern to get the maximum pressure for the residual limb. This is widely used because these soft dressings are commonly available and they are easy to apply, and also considering cost, they are very low cost. So other than the soft dressings, there are rigid dressing types also. The conventional rigid dressings, they were formed with the plaster cards. The disadvantage here is when applied rigid dressing, it's very difficult for scar inspection. But most of the researchers has found the outcome of the patient is much better using rigid dressings compared to the soft dressings. So now it has comes using removable rigid dressing types. Removable rigid dressings again can be using the plaster cards, or it can be using vacuum formed dressings type also. So now it is becoming popular, but in our setup, the most used ones are soft dressings in our resource settings. So this one shows these type of, this is how apply a rigid dressing with the wound dressing, and this is a removable, the below one is a removable rigid dressing type, and the middle one, actually it is a vacuum formed removable rigid dressing, and the corner one, it shows a rigid dressing which were formed for immediate post-amputation prosthesis type. So this one, actually it is, with this one, this post-amputation phase, patient, it helps the patient to be mobilized so early with that to improve the patient's confidence and restore the patient's locus of control, and also muscle strengthening. Everything will be very fast if we can use this type of initial post-amputation prosthetic type. So it is commonly used with the rigid dressing type, using the rigid dressings. So again, pain management is so important in this post-amputation phase. So it is a commonest physiological stressor during the acute post-surgical phase, which negatively affects the early rehabilitation. There are multiple etiologies for this pain. It can be come from the peripheral neurons, and again spinal cord, and also brain can give rise to this type of pains after this surgery, which and it badly affect leading to the several psychological factors such as stress and depression of the patient also. So pain types can be post-amputation or surgical pain, and further it can be residual limb pain, phantom sensation or phantom limb pain. This, we can do a pain assessment using the brief pain inventory, and also we can use visual analog scales, and also can manage with using the WHO pain ladder. Phantom sensation, actually it is normal for majority of amputees. It's commonly not a noxious sensation, but can be unpleasant. This is phantom sensation. It's commonly feel as a light tingling sensation. Usually it works with reassurance. We can reassure the patient regarding this, and it will make sense. So the other treatment options during this post-amputation surgical phase is the very important one is patient education and reassurance. And we have to optimize post-op analgesia and limiting edema, and also prevent contractures and addressing other musculoskeletal weaknesses, and also imbalance also helpful. Further, we can start desensitization of the skin, and also can try to distract the person. Further, early starting of the prosthetic training also found to be helpful. Phantom limb pain is the pain that is localized in the region of the removed body part. So it is still a poorly understood clinical phenomenon. There is no clear evidence and where from it is coming from. So we are using with different techniques. This phantom limb pain, we use different techniques to treat it. Can be there are medical types, non-medical, and also surgical types also. And there are no good evidence and what is the best treatment option for this phantom limb pain also. But with the several small studies has revealed medications like duloxetine, gabapentin, and ketamine infusions have showed some proven evidences there, but still from the small studies. And the TENS therapy, trans-electrical nerve stimulation therapy, continuing for 60 minutes, have shown moderate evidence to be effective for relieving phantom limb pain. And there are some researches are still going on for the place of botulinum toxin also, but still no proven evidence. So moving to the pre-prosthetic phase, this is mainly targeting the pre-gait training. Main components are residual limb shaping and also start gait training, muscle strengthening, and restore the locus of control of the patient. For this phase, we can use, to initiate the early mobilization, we can use assistive devices like walking frames, elbow crutches, pneumatic compression splints, and also, as I mentioned earlier, immediate post-operative prosthetic types also come into the place here. And if the patient is using a wheelchair, always we have to ensure that whether the patient is using a stump board for prevention of knee joint contractures. So further during this phase, we have to educate the both patient and also caregiver regarding bed mobility, transferring and positioning techniques to be done, how to done safely and preventing complications. Especially regarding positioning, we have to advise both patient and caregiver to keep the knee joint in flex position when the patient is on bed, and patient should advise to be in prone position even 15 to 20 minutes, 3 to 4 times a day to prevent hip contractures, and also to use a stump board when he's on wheelchair, as I mentioned earlier. And for the femoral, transfemoral amputees, have to advise on avoiding hip flexion and keeping the hip in abducted position for a long time. So, in this phase, further we can assess the patient's prosthetic mobility. We can do the prosthetic mobility prediction using several tools such as AMP-Pro and AMP-No-Pro. There are tools to assess the patient's mobility with the prosthesis and without prosthesis. And also AMP-Bilat there are 4 bilateral limb amputees. Socket comfort score and SIGAM mobility grades. Also, there are new tools for the assessing patients' prosthetic mobility with the prosthesis. So K-level, that is a rating system to determine the ability to use a prosthetic device, so which is calculated using amputee mobility predictor. And also it is based on the amputee rehabilitation potential of the patient. So there are K levels, K0 to K4. K0 mean that it shows the prosthesis will not enhance the patient's quality of life or mobility used in a prosthesis. So we mostly the prosthesis would not benefit this type of patients. From K1 to K4, K1 means that with the prosthesis he would be mobilized as a household ambulator. K2 means limited community ambulator. He can walk with the, even in the community with the prosthesis, but in a limited duration. And K3 is again a good typical community ambulator. That means he can use the prosthesis for a considerable duration for mobility. K4 means again a very good ambulation ability with the prosthesis, even can do sports and like athlete procedures using this prosthesis. So further, physiotherapists have to do a very good physical assessment prior to issuing the prosthesis for the patient. So he will use several physical activities to monitor these factors, like independent transfer into bed, chair and toilets, and again back, using a standing pivot transferring. And again, sit to stand, independent standing. These all basic interventions are measured by the physiotherapist prior to issue the prosthesis for a patient. Further, the negative factors like will also assess. We have to give the further concern when we are issuing prosthesis for the patient. We have to consider the muscle strength of the patient according to the MMRC grading and hand dexterity, inability for independent washing and dressing, presence of medical comorbidities like cardiac and respiratory. We have to assess the cardiac and respiratory function to decide patient's post-amputation physical fitness, and also the motivation. And further, very important is social support and home environment with the prosthesis. When we issue this, how he has to use it and the support, we have to consider all these things and decide whether we are proceeding with the prosthesis or whether the patient is going to have a wheelchair, or what is that goal setting is, should decide on these multiple factors. So this shows below-knee prosthesis and the transtibial and transfemoral prosthetic type. So a good and comfortable, well-fitted prosthesis ensure the positive outcome of amputee rehabilitation, and transmission, and also the stability and control of the prosthesis. We have to ensure all these things with the prosthesis for the patient. Why many patients stop prosthesis wearing is commonly due to the problems related to the sockets. So it can be a poor fit with the poor biomechanics and reduced control of the prosthesis with the non-fitted socket. So further, socket is the primary and critical interface that is between the residual limb and the prosthesis. So quality of this socket design greatly matter for a good prosthetic fit, and followed by users' comfort and control of the gait. Hence, this is very important part which should be properly created by a very well-experienced prosthetist to create the best and optimum socket for the patient. So the socket fabrication will involve the measuring of the stump, and then taking a negative cast, moving for the taking a positive mold, and followed by rectification, and then leading with the definitive socket creation. So this picture illustrates the pressure-sensitive and pressure-tolerant areas of a stump. Here the transtibial and transfemoral stump. Especially when we are creating a socket and developing the prosthesis, we have too much concern regarding these places, especially the pressure-tolerant areas and pressure-sensitive areas. It's prosthetist responsibility and it's his ability to avoid the pressure-tolerant, pressure-sensitive areas and develop the socket as the weight is leading to the pressure-tolerant areas when he is developing these sockets. So in the transtibial amputees, the socket mainly we are targeting for the patella tendon. The weight bearing should be targeting for the patella tendon. And for the transfemoral amputees, the socket will, the weight will mainly targeting for a scaled tuberosity. So this here you can see several socket types. Okay. So yes, so here you can see the several transtibial socket designs. Here this is a patella tendon weight-bearing sockets, and yes, the last one is a total surface bearing socket. So this is more comfortable and tolerable for the patient. And there are several suspension systems we are using with these prostheses. Here you can see the commonly used one, and the newer one is osseointegration. It is commonly used for bony amputations, which is attached to the remaining femur bone. So there is no sockets or liners, so skin complication will be minimum. And regarding prosthetic phase, we have to initiate the, we have to do the, aim is to get the highest possible independence level with the most efficient gait possible. So using the observational gait analysis and validated outcome measuring tools, we have to act as a multidisciplinary team to achieve our goals previously set. And these are the interventions that are doing for achieving the balance and coordination of the gait with the prosthesis. Again, this is alignment with the prosthesis is very important. We have to look for the alignments, and any malalignment is there, we have to correct them soon to avoid complications. And after the patient is discharged, the very important to follow up the patient in the community. And if the patient should be well advised to review again in the rehabilitation clinic any complications is occurred. And also very important to look for the secondary complications like osteoporosis, osteoarthritis, and lower back pain, and look for the causes. According to the ICF framework, we have to look for all the interconnected factors like activity and participation, which are limiting the patient's activity and participation, and we have to address those things, especially the environmental factors, which are very commonly see the barriers in our environment, physical environment, mainly the home, workplace, public places, transport systems, and educational institute. We commonly see only the barriers and very minimal modifications for amputees and other patients with disabilities. Again, the social-wise, we have to look for what are the supportive systems and what are the assistive psychological support we can give for the patient. And there are multiple policies and legislations in our country also, starting from 1996, Act number 28, but still very minimally implemented in our society. So we have to focus on those things. So I'd like to conclude with mentioning amputation is a new beginning for a person for a new way. So early successful rehabilitation definitely increase the outcome. And we have to know all amputees need rehabilitation, may not a prosthesis. And the prosthetic assessment for amputee is really paramount. And the recruitment and training of efficient rehabilitation team also very important for a successful rehabilitation outcome. And finally, we need a powerful advocacy for the establishment of social and environmental supportive infrastructure by enforcing responsible administrators and should be highlighted for the efficient rehabilitation outcome. So, yes, I think this should not be a dream for our setup also. So these are my references, and I like to thank you for all my trainer, Dr. Duminda Basing, and all the consultants and other peer teams with continuously support. So thank you. Thank you.
Thanks again for that very informative and methodical lecture. So the next CME is on the 7th of March, 12 noon. Please be present for that. So we conclude the CME activity now. Please sit back for a few minutes of a pain score introduction by a pharmaceutical company. Thank you.